Hello, everyone, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors, Stonebridge Biopharma, Pfizer, Novartis, and our expert presenters, Drs. Van Gumpel, Chobe, and Welch from the Mayo Clinic. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and the donors to bring valuable resources and programs for the patient community. Today's webinar title is Pituitary Surgery During the COVID-19 Pandemic. Our presenters are Dr. Jamie J. Van Gumpel, Professor in Neurosurgery, Otolaryngology, specializing in endoscopic, open skull base focusing on pituitary tumors, as well as epilepsy at the Mayo Clinic in Rochester, Minnesota. And his associates, Dr. Garrett W. Chobe, a fellowship-trained rhinologist and endoscopic skull base surgeon practicing at the Mayo Clinic. Dr. Tasha L. Welch, a fellowship-trained neuroanesthesiologist practicing at Mayo Clinic. They will be joining him in today's webinar. There will be a brief delay while I turn the webinar over to Dr. Van Gumpel. Okay. Dr. Van Gumpel, it should be ready for you.
Thank you, Jackie. I think I got it. Let me know if I have it.
Looks good. Just go ahead and start. Thank you so much.
Perfect. Well, thank you so much for the opportunity to present and hopefully share some, at least our perspective on how this COVID-19 or SARS-2 pandemic is going to affect, anybody that's listening to this webinar with particular pituitary disease or tumor. And we were all introduced before, but let me see if I can advance. But again, I'm Jamie Van Gumpel.
I'm Garrett Chobe.
And I'm Tasha Welch.
And we all work together at the Mayo Clinic as a team, taking care of pituitary tumors. And again, we have representation from myself and Dr. Chobe doing these cases together, and Dr. Welch, who's an expert neuroanesthesiologist who takes care of a lot of these patients for us and probably has more pertinent information than we do on these. But we're going to try to keep this light and conversational. Hopefully we'll get some good questions and hopefully try to bring you guys good knowledge that you can use going forth. And obviously what we're talking about today is going to be a snapshot in time as things are happening quite rapidly. But here we go. We have no disclosures within this talk. We're not going to talk about anything off-label either. And our objective is purely to try to bring practical information to this group of people in the PNA during the COVID-19 outbreak, because as you know, there's a huge amount of misinformation, which right now in which most of us are getting our sources from social media. And if you follow the news right now, obviously Facebook and YouTube and all of them are trying to figure out how to keep the conspiracy theories and the misinformation off the internet right now. So we're going to try to dispel some of the myths and try to get just again practical information that you can use if you are facing surgery during this particular crisis. This is one of these COVID apps. I don't think this is fake news, but this is from last evening. And as you're all aware, at least as of last evening, there's 4.2 million cases worldwide. And in the United States, 1.4 million cases, and we surpassed 80,000 deaths in the United States. And obviously, this is a worldwide crisis, as you've already heard.
We thought it'd be a good idea just to get some of the nomenclature set straight, because this can be a little bit confusing as you discuss both its virus as well as the disease process. So as many of you are probably aware, that the disease itself is caused by a novel coronavirus, which is actually a fairly common family of viruses that causes the common cold and other upper respiratory infections every year, especially in children and in adults as well in the wintertime. This is a novel strain of it, which is an RNA type of virus that is this disease process called the COVID-19, or the coronavirus disease 2019 is how that was named. And this is a highly contagious respiratory disease. So it primarily affects areas of the throat, the nose, and the lungs. Its classic symptoms are fever and cough, and sometimes other flu-like symptoms can also arise associated with it. There we go. Now, of course, when it comes to doing pituitary surgery in this time, there's been a lot of concern about proceeding with these cases, at least in the early days of the virus. We know from several studies that the area of the highest viral load is in the nasal cavity, as well as the nasopharynx, which is the area in the back of the nose right at the top of the throat area. And of course, this is a concern as we think about this, because we're doing surgery through the nose, and these surgeries are considered aerosol-generating procedures. So certainly with high viral load in the nose and the nasopharynx, that was a concern in the early part of this disease process. Now, this is just a little illustration to show that, as many of you are aware, the current testing is being done via a nasopharyngeal swab. And that swab is a small Q-tip placed through the nasal cavity along the nasal floor. And its mission is to get to the very back of the nose and swab that nasopharynx. And again, illustrating that this is the area of the highest viral load, and such the reason why it was chosen for the area of this swab.
And that's pretty much the pathway, Dr. Chobe, that we go through for this procedure, correct?
That's exactly right. So this is, a very, very similar pathway in the trajectory we take when we undergo transnasal pituitary surgery. Now, it's also important to note that one of the main symptoms of this COVID-19 disease, or the coronavirus, is a loss of sense of smell, or what's commonly called anosmia in the medical world. Dr. Van Gumpel and I see a lot of patients postoperatively who have temporary anosmia following surgery, which is a very common thing that generally comes back. However, in almost 1 in 5 patients with COVID-19 disease, they have anosmia as their primary symptom. In addition, about half of patients who present with this disease process have both anosmia as well as fever or cough. So it is a very common association with the coronavirus as well as the COVID-19 disease. Now, loss of sense of smell from a viral infection is not a new thing. It's actually, outside of the coronavirus, one of the most common reasons to have a loss of sense of smell. But certainly in the current environment and pandemic, if someone has anosmia as well as fever or cough, it puts the COVID-19 disease high on our radar.
So we're going to go over a case example of something that happened right at the start of this pandemic in our particular practice. And it kind of gives just a flavor of, what do you balance not doing surgery versus doing surgery. So this is a 60-year-old woman with progressive vision loss, blurred left eye, not currently useful. Right vision, she could tell that there was some issues with it, or reduction in vision. The ophthalmologist office wasn't open to do formal field testing, but her left eye had severely restricted vision, and right upper outer visual fields were affected in this particular patient when we saw her in the clinic. She was set up for surgery. The day prior to surgery, all procedures were halted except for truly emergent cases, so I had to call this patient and tell her that we couldn't do surgery. She was not that happy about that. So 3 days later, it's Monday, and she calls me and she says, hey, I can't, now I have a worse vision on my right side and I'm having a hard time reading. And then, so at that point in time, we couldn't get anybody to substantiate that, and I had to take the patient obviously at her word. And we were able to finally convince someone to get an operating room by the following Friday with necessary approvals. And in which, at that time, she reported that she is having some difficulty with anything but light in that eye. And we thankfully were able to get her back to surgery and get her vision back. But this is a dramatic example to show that, you can't wait for everything to go away, or you can't wait for this to go away, because sometimes people need surgery to fix the problems for these particular tumors. And this patient had an ACTH secreting tumor, which was well managed, and she ended up doing very well after surgery.
What we also wanted to mention was, along this same time course, early on the outset of this pandemic reaching the United States, there was a lot of, to be quite honest, fear within the world that Dr. Van Gumpel and I live in of doing transnasal pituitary surgery. There were several cases both from China as well as Italy, at least anecdotally, where a lot of spread of disease was carried out during transnasal pituitary surgery, likely in patients who are asymptomatic carriers of the disease. And again, because such a high portion of the viral load is within the nose and the nasopharynx, there was fear that you would be rapidly spreading this viral load throughout anybody who cared for the patient in the operating room or even postoperatively. This created a lot of sort of stir early on and fear at the outset of the disease, especially before we had good testing available. And this brings us to currently what precautions are being taken for patients who have pituitary disease or are undergoing pituitary surgery. And currently at the Mayo Clinic, we have a number of things in place, and this is probably reflected as well at many other centers across the country. The first thing is that all patients are asked a number of screening questions, ensuring they don't have symptoms such as fever or cough or those kind of things, and also they don't have a known exposure to someone with the COVID-19 disease. In addition, all patients are undergoing a nasopharyngeal swab 48 hours before surgery. And as I showed you earlier, this is where testing for the virus is carried out through a swab in the back of the nose. And then lastly, all patients are also undergoing a serum antibody testing, which is a blood draw, again, approximately 48 hours ahead of surgery. And this allows antibody testing for both active infection as well as previous exposure that has allowed the patient to develop antibodies to the virus.
And building on what Dr. Chobe said, this is an example of the timeline of things that, at least at the Mayo Clinic, where we went through trying to mitigate the risk not only to the otolaryngologist, neurosurgeon, and anesthesiologist, but also to the patient, and trying to, first off, set up a hospital in which has the lowest number of cases that we can have, and also help the patients we need to, in addition to keeping the physicians safe. As you're aware, obviously there's been several physicians on the front lines have problems with this disease, and some actually die. So from March 23rd to April 5th, we only did emergency cases, as we just mentioned in that last case, and we were trying to do at that time 5- and 2-day SARS-2 tests with the chest CT, which didn't last very long because it turned out that the 5-day test wasn't that valuable. From April 6th through April 24th, we were doing still all urgent cases with 2-day SARS-2 tests and chest CTs. And the chest CTs themselves were meant to try to pick up asymptomatic disease but problems in the lungs. From April 27th to May 1st, we were just distilled this down to 2-day SARS tests. And now from May 2nd to current, we've added not only the SARS-2, which is a PCR test, and we'll go over that in a second, but also a 2-day IgG SARS-2 serology, which tells us if you've been exposed before to it and may help us understand if you have any risk after the operation or less risk after the operation of developing the virus. And this is our current mitigation strategy, in which we, as Dr. Chobe mentioned, screen patient with questions, and if you're clearly sick, we say don't come for now. If you're a sick patient but yet have an urgent issue, that doesn't mean you can't come. That means that we have to take special precautions in the operating room, which we'll discuss later. We then order a SARS-2 COVID-19 PCR and serology. If it's the PCR itself, which is meant to pick up active disease, is negative, and regardless of the IgG status, you're in a low risk category and you can go on with surgery. If your IgG is indeterminate, but your PCR is negative, you're in an intermediate risk category, meaning that you may have developed a response to the virus itself, but we cannot detect it in your nose, and we would then repeat the PCR and delay your procedure. Alternatively, if you're positive, we then put you into quarantine, or suggest quarantine at that time, and repeat testing in 7 to 14 days, and that's based on each particular event. So the two tests that you might experience, as Dr. Chobe pointed out earlier, that cotton swab that goes down the back of the nose. And in some patients that it can't go down the back of the nose, they swab the back of the throat. That test is meant to pick up some of this RNA or the genetic code of the virus that then gets PCR, which is something that amplifies that genetic code. And that particular test is 99% specific for this pathogen and 96% sensitive. And if it's negative, the negative predictive value that you don't have an active infection is 98%, which is actually quite good for this type of a test. Serum IgG studies, that's where we take blood from a vein, and we look for whether or not you've been exposed to the virus. And after you've been exposed to the virus, your body builds these things called immunoglobulins that may, in fact, be able to fight the disease itself, but it at least provides evidence that it's been in your body. And at least the studies that we've done here in 150 normal donors, the IgG antibody test is 99.3% specific. The cross-reactivity is actually very good. In fact, even with other COVID, other coronaviruses, it appears to not have a lot of cross-reactivity as it shows in this table below. And the overall specificity for COVID-19 is quite high, actually, at 98% with early limited data. Of course, we'll know more with time as we continue to collect that same data. And in those sensitivity studies, 0% of patients' blood that was tested were IgG positive in samples collected that were less than 7 days post-symptom onset. And then over time, at 32% of patients' blood was then positive in samples between 8 and 14 days, and 100% of specimens collected after 14 days of those that were actually actively infected developed IgG positivity with this particular test. And this is what this looks like, okay? So in the initial stages, you're exposed to the SARS-2, or you develop SARS-2 as a syndrome, and that's the COVID-19 virus. And then you end up having this upswing in replication of the virus. In the first week or two, you then demonstrate positivity with the nasal swab. So if we put something in the nose, what we see is we see the active presence of that genetic structure, that RNA of the virus. And then over time, as your body mounts an immune response with immunoglobulins, the overall disease presence then reduces as the body is able to fight the virus off for itself. And although we don't know how long that immunoglobulin presence is, it could be weeks, it could be months, it seems to stick around at least long enough to detect patients currently that have had past infections. And that's something that we're using to try to understand who's had it and who has not had it in the past. So we kind of touched on this before, but we get screening. If you're to come here for surgery, if you're negative, you can come to surgery. If you're positive, it's between 7 and 14-day quarantine, depending on the stage of disease. And then we also oftentimes involve our ID colleagues and discuss the next step. If it's an emergency case, we do it with specialized equipment that reduces the risk of transmission. If you are negative, and Dr. Welsh will talk about that protocol coming up. And for all of our cases, we're protecting ourselves with in the OR with N95 masks. So which type of pituitary case you should have surgery? At this point in time, we don't know when the pandemic will subside, but our recommendations are for patients that have functioning pituitary tumors, such as ACTH or tumors causing Cushing's disease, growth hormone secreting tumors causing either acromegaly or gigantism, or thyroid stimulating hormone tumors, which are incredibly uncommon, that those patients undergo surgery as they would have before with appropriate screening. Tumors causing problems with mass effect, most commonly causing vision loss, should also be screened, or should also consider surgery, especially if that vision loss is rapid in onset. And each case is a little bit different, but you should discuss it with your physician as to if they believe you can wait. I would recommend surgery if you have active evidence of vision loss. Growing asymptomatic tumors will be case by case depending on the tumor. But again, without knowing how long this will last, if you have a growing tumor that we estimate will cause problems, I would consider doing surgery. And then tumors that can be watched are asymptomatic non-growing tumors. Even these are tumors that we would have watched before the pandemic. And then another question that one might ask is, does pituitary surgery burden the system? So if you're to choose to have surgery and you go to a hospital and have surgery, are you creating a problem for patients that may be sick? Well, typical pituitary surgery is 1 day in the hospital and then 1 day out. It's greater than 95% of those patients that at least we do here are dismissed post-op day 1. There's no ICU level care of need. And the typical case operative times are between 60 and 100 minutes. The chance that you'd have to be readmitted after an operation would be approximately 2% for a CSF leak or 3.3% for any other problems such as sodium issues after the operation.
Thank you, Dr. Van Gumbel and Dr. Chobe, for inviting me to participate in this webinar. I think it is important for patients and people with pituitary concerns to understand the steps that the anesthesia and surgical teams are taking to keep patients and staff safe during this current pandemic. So something I always tell patients when I meet them is, as the anesthesia team, our first priority is always your safety, patient safety. So my first job is to keep you safe. My second job is to keep you comfortable, and that does not change in the current environment. The information that I'm going to present is mainly from the recommendations of the Anesthesia Patient Safety Foundation and the American Society of Anesthesiologists recommendations for caring for patients in this current climate. And just so everybody knows, the recommendations are that we basically care for every patient like they do have COVID-19, even though we do have the current testing ability here at Mayo Clinic. And the stuff I'm talking about is really what we're doing here at Mayo Clinic Rochester. I can't comment on other facilities throughout the United States. Can I use that? Is that okay? So some of the steps that we're taking, and we're fortunate to be able to do here, is providing appropriate personal protective equipment for all staff that are participating in the care of patients undergoing pituitary surgery. And that equipment includes surgical masks when we're having regular interactions with patients, like all three of us currently are sitting in this room with surgical masks on to try to limit transmission of the disease should we be asymptomatic carriers. We are using N95 masks or PAPRs for any aerosol generating procedure, which includes placing a breathing device to facilitate surgery. We also use face shields during those aerosol generating procedures. And then something that's not on this list, but we wear and use for every procedure, is a gown that is not permeable to fluids, and then gloves as well, of course. So patients probably have concerns about entering a hospital during this time for fear of contacting COVID-19. So I'd like to kind of walk through some of the steps that we are currently taking here to try to ensure the safety of our patients and our staff. So some of the safety precautions prior to surgery for patients include, of course, universal masking for all patients, visitors, and staff on our campus. Additionally, we are encouraging any social distancing while we have patients and families waiting in lines. Should there be lines, we're of course trying to expedite any waits that might be occurring to prevent people being around each other. So once you're past the line through the admissions desk, we then have patients go to individual preoperative rooms, which is the standard at this particular hospital anyway, but to ensure patients that they are physically distant or separated from other patients in the facility. The other thing that we do at Mayo Clinic Rochester is ensure at least 7 air exchanges in the operating room prior to essentially anybody entering the operating room, unless they are wearing an N95 mask or a PAPR. A PAPR is I forgot to mention that, but a basically hood with a filter device that filters any air that's going into the hood to remove any viral particles. But allowing these air exchanges to occur before people entering the operating room allows for over 99% of airborne pathogens to be removed from that area. So there's at least 7 air exchanges before staff enter the operating room and well over 7 air exchanges before any patient enters the operating room. Additionally, all surfaces are cleaned with disinfectants that have been proven to be effective against the virus that causes COVID-19. Now, the basic safety during any type of procedure is, of course, hand hygiene. We are meticulous with our hand hygiene, but we are even more so meticulous with hand hygiene in the current pandemic. We basically can't get enough bottles of hand sanitizer in the hospital to facilitate the hand hygiene, but we do have enough, and we're very fortunate to be in that situation where we do have enough to facilitate this. Also, the surface cleaning is meticulous. We're trying to minimize staff that are present, basically in any particular situation, unless they're absolutely necessary for that particular situation. So when we're placing a breathing device, we have only anesthesia personnel in the room, or if we anticipate a particularly difficult airway, we would ask one of our ENT colleagues, like Dr. Tolby, to be in the room with us to ensure the safety of the patient. But this minimizes any exposure that the patient would experience from staff that would otherwise be unnecessary. It also ensures safety of the staff by minimizing their potential exposure. Other things that we're doing, when patients wake up from anesthesia, it's not uncommon for people to cough and for some people to experience nausea and vomiting. So we're really trying to maximize the techniques that we have to minimize coughing while we're waking patients up and try to minimize vomiting, because this will help reduce the viral spread of COVID-19 as well. I think this particular slide will be hopefully reassuring for our patients and my surgeons here.
Yes, thank you.
So what we do, and we've done before the pandemic, is we do use high-quality bacterial and viral filters on our breathing circuits between the breathing circuit and the anesthesia machine. Can I see this? Okay. So I have the mouse pointing out the breathing circuit. These little pieces on the end are the viral filter. So we have one that goes with the air going into the patient from the anesthesia machine. So already the air that's going into the patient is filtered. Air that comes out from the patient is then filtered before it goes back into the anesthesia machine. And we're also placing a third viral filter between the breathing tube that goes in and the breathing circuit. So there are 3 viral filters with a viral filtration efficiency of 99.99+%. So this really helps us prevent contamination of the anesthesia machine, which maximizes safety to the patients and to the staff. And then if at any point we need to disconnect the anesthesia machine or the breathing circuit from the breathing tube, which would be right here, we have that viral filter on. So if a patient exhales, their exhaled breath is being filtered by that viral filter that's in place. So the other thing that we do, and actually we routinely do this before the pandemic, is we try to use disposable equipment anyway, so that it's a one-use piece of equipment. It's used for individual patients and then it's disposed of. And this is, again, our usual standard of practice, and this has not changed during the pandemic. Again, we clean our surfaces all the time. And then we're also using a double gloving technique to avoid contamination of surfaces. So anytime we touch something, we take a pair of gloves off, clean the gloves that are on our hands, and then put a second pair of gloves on top of that. And that helps reduce the amount of contamination that can occur. And there are studies that prove that particular technique. So I think it's important to mention postoperative safety in patients, because your care in a hospital during surgery doesn't stop with surgery. It continues in the postoperative period. So here at Mayo Clinic, our practice is to have patients be recovered from anesthesia in individual post-anesthesia care unit rooms. So again, you are physically separated from other patients. Any transport of a patient from an operating room or any room to a post-anesthesia room or to a testing room, all patients are masked and all staff are masked. That includes any transport staff, nursing, surgeons, anesthesia. Literally everybody that's walking around has masks on. So that helps reduce the transmission of any disease between people. We also try to transport our patients to their individual hospital rooms as soon as possible from the post-anesthesia unit so that it limits their time in the post-anesthesia care unit. We can get them to their hospital room where they will be for the duration of their stay. Need to cover this one?
Yeah.
So one question that people likely have is it more likely that I will get COVID-19 after surgery due to intubation or medications that are used during surgery? So I did a very thorough literature search and researching on those two society websites that I told you about, and there is no data to support either way. I'd say it's highly unlikely that you're more likely to get COVID-19 because you're being intubated. We're very sterile using our clean techniques. Everybody is tested. Our staff are well screened. So your risk of getting COVID-19 is probably less than if you were to go to Target or to the grocery store or to Walmart and touch other various surfaces. So that's how I would comment on that. I don't know if you guys have some input.
I'll build on that question for Dr. Chobe. So if we take or mobilize the respiratory mucosa or the nasal mucosa, do you think that makes any difference in whether or not they would be more susceptible or less susceptible to an infection since the virus lives there?
Yeah, it's a pretty provocative question and something we've given a little bit of thought to as well. We've recently worked on publishing a study that looked at all people who were tested within the Mayo Clinic facilities, either in Minnesota here, Jacksonville, or Arizona. And we looked at certain conditions that may predispose them to getting COVID, things that would make the nasal lining maybe more susceptible to getting the virus. And we looked at things like chronic rhinosinusitis or allergic rhinitis and those things. And it did seem like those patients were getting tested more often. And maybe that's because some of their symptoms overlap with COVID symptoms. In other words, they have symptoms of maybe smell loss more often or nasal congestion or blockage and those kind of things. However, it didn't seem like they had more positive tests on average than a patient without chronic rhinosinusitis, for instance. So I think the data is a little bit debatable at this point in time, but it doesn't seem like you would be necessarily predisposed to that. Although it is a provocative question, when you have disruption of your nasal mucosa, which does give you some natural immunity, it is provocative to say, I wonder if in the postoperative period, if I would be more susceptible. What I can tell you is we've been operating through this pandemic every week. Dr. Bingham and I have had cases together throughout this whole time for emergency, and then as things have changed, more elective reasons. And we haven't had, knock on wood, a patient that's come back to us with a positive case yet. But I don't think we know the definitive answer to that question.
And to follow that up, there are some reports of people developing intracranial problems, so bleeds and some neurologic conditions with this. And as best we know, we don't know if this transmits in through the smell nerves or the olfactory nerves, or if this comes in from the blood spread, so viremia. But we don't have any evidence to suggest that surgery would make that any more likely at all. Dr. Welch, if someone were concerned about atelectasis causing problems at the operation, what kind of things could they do to maybe reduce their atelectasis?
Well, participating in the pulmonary hygiene that's recommended by the respiratory therapist, which usually involves deep inhalation or breathing against certain devices that the respiratory therapist can provide can help kind of stent open that atelectasis that it can occur after an anesthetic. I don't think having atelectasis from surgery places one at higher risk for contracting COVID. But I guess the best thing to do would be participate in pulmonary hygiene as recommended by the respiratory therapist.
Awesome answer, I will say.
And we'll just mention to the folks who are participating in the panel, we have a couple of questions we knew would likely be questions which we're going to go through currently, but if you do have questions, do feel free to send them in, and we will address them as things wrap up here.
So another question one might ask is, does it matter where surgery is done to affect my risk of acquiring the virus? And I think while nobody really knows the answer to something like this, I think systems that have thought a lot about every phase of care probably have a less likelihood of actually in-hospital transmission, as Dr. Welch was kind of explaining how detailed anesthesia has looked at this and how Dr. Chobe was looking at, or talking about how our colleagues in ENT have managed this, and we have done a deep dive into this as well in neurosurgery. But a lot of the big centers across the country have done something similar. They have the resource to do so. It does make logical sense, though, that traveling to a center that has a high number of cases in the community may increase the risk of potentially acquiring the virus as well. So being quarantined in that community is something to consider when looking at places to have surgery during this period of time as well. Does you have anything to add to that?
I just also mentioned it, even outside of having surgery, if you're going to a community with a high case load, even going to things like the grocery store or Target or whatnot may, put you at somewhat of a higher risk if it's a very high volume area. But I don't think we know the answer yet. If it's a higher case volume area, if having care in that facility would actually put you at a higher or lower risk. But again, with epidemiology, just common sense, it's something to think about and to consider.
I think Dr. Welch probably touched on this better than any one of us, but is the hospital safe? Is it in an unsafe environment for me? Are you at higher risk of getting it from another patient? And as Dr. Welch initially said, everything is individualized rooms nowadays in most hospitals. And obviously the patient flow is really aimed at sequestering patients from each other and also protecting staff from each other. Do you have anything to add to that?
No, I mean, every practice that I've seen, and I work in a lot of the surgical areas here, it seems like we are trying to make sure we keep the distancing. I've seen way more, disinfecting surfaces right away after people leave and making sure we set the clock to make sure everything dries appropriately. So.
The other thing that I'll mention is that I see my patients in the clinic setting in an outpatient area. It's in a separate building from the main hospital where we do surgery typically. And nearly every patient that comes to see me in clinic gets a nasal endoscopy or a nasal scope done during their clinic visit, which is considered an aerosol generating procedure. So we have some additional protocols in our clinic that have been set up from our hospital leadership. So every patient coming in, even for a scope, gets those 2 negative tests before coming in. And there's very specific protocols that are done, including room turnover time in the clinic that mirrors that in the operating room, which allows that active room turnover of air to prevent generating, things across, even after patients have all undergone 2 negative tests pre-clinic. So I will say that even outside of the inpatient hospital setting, our outpatient world where we see patients in clinic has also sort of mirrored that hospital world.
There is also efforts, not only at our hospital, but I think many hospitals across the country, where for elective or urgent surgical patients, they try to set up the hospital as a COVID-19 free zone, meaning that if anyone develops an infection in the hospital during their hospitalization, they're moved to a specialized unit, again in individual rooms, away from most of the surgical practice.
Yeah. The last thing I'll mention in this one as well is that, as Dr. Van Gumpel mentioned earlier, there are situations that arise where a patient does need emergent surgery, and perhaps there's not enough time to go through full testing or making sure their serology is negative. In those cases, of course, we are proceeding with surgery for those emergency reasons, and we're simply taking those precautions that help prevent virus spread no matter what the exposure status of the patient is, things like N95 masks, universal masking, et cetera. And those things are still going on for those emergency cases, even when the full gamut of testing can't be completed preoperatively for timing reasons.
We just kind of mentioned this, the COVID-free zones are becoming common, so we can kind of skip over that. So who particularly might want to wait it out? If you're out there, and you're paying attention to a lot of the the data, at least in Minnesota, where Mayo Clinic is currently, there's 578 deaths since this started. 464 of those patients were in long-term care facilities. And it turns out that if you're over 65 or 70, there seems to be a higher risk simply of dying from the disease, and it gets higher per every 5-year epoch after that. So if you look at the bottom slide, and this is from the cdc.gov, 85 plus patients that have been infected with this have a death rate between 10 and 27%. So those are the patients that not only if you're listening to this, you should really think of quarantining yourself, at least for the foreseeable future for now, until there's more progress made on vaccinations and so forth. Additional things that might be concerned if you have severe asthma or a substantial COPD, if you develop an infection with COVID-19, you're going to have a harder time to manage it because it is primarily a respiratory disease. HIV is an immune suppressed situation, and patients may have a harder time with this, although it doesn't seem like there's a lot of data out about that. And then liver disease are also at higher risk as well. That's pretty much everything we have. I wanted to thank Dr. Welch for joining us and Dr. Chobe. And I think the take-home message is that, if necessary, pituitary surgery is safe during this pandemic because there's a lot of really smart people out there at most institutions spending a lot of time thinking about how to do this safely. And I think in the end, the needs of the patient come first. At least that's our mantra here. And everybody that's involved is taking this seriously and taking it seriously to a point of making your experience still a good experience at the hospital and also a safe experience. And with that, we can turn it back over for questions. Jackie, I don't know if you're there.
I'm here. Thank you so much. On behalf of PNA and the webinar attendees, we appreciate your presentation straight from the operating room, OR 701, our very first OR webinar, and all you do for our pituitary patients. We did have a question come in. How are ventilators cleaned to make sure they are not transmitting COVID-19? And are new ventilators used for non-COVID-19 patients only?
So I touched on the viral filters that we have in place that we put on our breathing circuits, which are attached to the ventilators. And so effectively, the air that's being put in and out of the ventilators is all being filtered at a 99.99+% efficiency for viruses and bacteria, and that's how our ventilators are kept clean. If we have a patient who is COVID positive, we do have an OR, like a known COVID positive patient goes to a specific OR that is a negative pressure room, but that ventilator, again, they have those 3 viral filters placed. 701 is not one of them. Not one of the positive ORs where we take our positive patients. We don't have new ventilators that are used for every patient. As you've probably heard in the news, that ventilators in the recent months have been a shortage, but they're also hundreds of thousands of dollars a piece. And so I don't think any facility can really justify the purchase of a new ventilator for every patient.
Just to point out, though, and thankfully we are sitting in the operating room because it triggers the thought here, is that most of the circuit that Dr. Welch showed you, as she said, was a lot of this stuff is disposable. A lot of the available breathing area is actually thrown out between patients. The only, I don't know if it's called the billows, but I used to say, but there's only one area that's an air generating area that's being protected by these, right? So the majority of the dead space in the ventilating machine is actually exchanging between patients.
True. Yeah, so the breathing circuit that I showed on that slide, that is disposable, and every patient gets a new one that has not been used by any other patient. The mechanical portion of the ventilator with like the metal and the bellows and that type of thing, that's the part that's not disposable and is hundreds of thousands of dollars. Yes. But thank you for bringing that up. That's a very good point.
Okay, great, thank you. It looks like you covered the material so well, there's not any more questions today. So that
Everyone's sleepy.
that will conclude our webinar today. And we really appreciate you being here. We appreciate everybody for taking the time to join us. If you missed any part of the webinar or if you'd like to share it with family members or friends, it will be available on our website, www.pituitary.org. After I edit it, there will be a brief survey after the webinar concludes. Please fill it out to help us provide you with the information you need. And thank you for joining us. Enjoy the rest of your evening.
Thanks for having us again. Appreciate it.
Thank you so much.